Okay, so my talk today is on upper limb tendon transfers. It's a topic that probably most of us don't know a great deal about, but I definitely learned something preparing it, so hopefully you can take something away from it. So today I'll go through what a tendon transfer is, the history of the procedure, the indications for its use. I really want to touch on the main principles involved in tendon transfers, and then look at the individual transfers that we're likely to see or refer on to our plastics colleagues, and I'll briefly touch on the post-operative management of these patients. So mainly for the students and residents, a tendon transfer is detachment of a functioning muscle tendon unit and from its insertion, and then reattaching that to a tendon or a bone to replace the function of a paralysed muscle or injured tendon. This procedure really came about in the 19th century with the polio epidemic of Europe and with cerebral palsy, mainly with lower limb type transfers initially. However, the world wars created obviously a lot of traumatic injuries, and this is where all the current techniques are all pioneered. These surgeons were all very important in the beginning as far as tendon transfers. Leo Mayer was an orthopaedic surgeon in the early 1900s. Sterling Burnell is probably the most famous hand surgeon going around. Guy Pulvertaft basically developed the weave technique for end-on-end anastomosis of tendon transfers, and Joseph Boys was also important in developing many techniques. So as far as why we need to use tendon transfers, peripheral nerve injuries are by far and away the most common reason for using transfers. It's also used for brachial plexus type injuries. So for the nerve injuries, those that need transfers may be physically irreparable, such as nerve root avulsions. It includes nerve injuries that do not recover after repair or grafting. And sometimes we actually use tendon transfers as a splint, internal splint, why the graft is taking. And also for those peripheral nerve injuries that present late, they undergo end plate fibrosis, therefore a nerve graft would not work in that situation. We also need to use tendon transfers in traumatic loss of muscle or tendon, such as in open injuries, or in closed tendon ruptures, such as in EPL ruptures after a distal radius fracture or rheumatoid hand deficits, and central neurological deficits such as spinal cord injuries or cerebral palsy are also common uses for tendon transfers. So in reading the literature and some textbooks, I came up with 9 principles, and I'm going to go through each one of these individually. So number 1, you need supple joints before the transfer. So you've got to maximise the passive range of motion prior to the procedure. This involves using aggressive therapy. Any contractures which are present must be released in a procedure prior to the transfer, because you're going to protect the transfer with immobilisation. If you try and release a contracture at the time of the operation, it's just not going to work, and you're never going to get a range of motion actively better than the passive range of motion at the time of the transfer. So soft tissue equilibrium, that basically means you want a healthy bed of tissue. So you don't want any edema, any inflammation or scarring. It may take up to 4 to 6 months following the time of injury before you can be ready to do a tendon transfer, and you may need to wait that time out. You want the tendon to glide freely, and if there's any scar tissue, you may need to excise this, possibly put a graft on it or a free flap over that defect. You need a donor of adequate excursion. So excursion is a term probably not everyone's familiar with. It's interchangeable with the use of the word amplitude. So it's the maximum linear movement of the tendon, and I'll elaborate on this in the next slide. But each different muscle tendon unit in the forearm has a different excursion. So we can look at this graph on the side over here. So FDP and FDS, so the extrinsic finger flexors, have the greatest excursion, and moving down to Brachioradialis with less than half of FDP. So that's important in regard to which muscle tendon unit is going to transfer. There's a couple of ways it can be increased. By mobilising the muscle proximally, can increase the excursion, and the tenodesis effect. So this is a really important point. Tenodesis effect basically says that the patient can change the excursion or amplitude of the tendon by changing the position of the joint. So you need a mobile joint for this to work. For example, if you have your wrist and you extend your wrist, your fingers are going to want to flex. However, if you flex your wrist, then you're able to extend your fingers further. So someone who has a tendon graft, which is tight in extension, can then flex their wrist forward and have better use of their fingers. So excursion here, you can see in this diagram, it's the length from the muscle contracted to the muscle with full traction on the tendon. And the tenodesis effect, we can see in a diagram of this. So you can see here that in wrist extension, the fingers want to flex. However, if you take the wrist into flexion, you're able to get full extension of the fingers to augment the graft. In regard to the strength of the tendon transfer, you want to have muscles which are relatively equal in strength. So you can see here that the muscles definitely differ in their relative strength. Brachioradialis and FCU are the strongest, and these are up to 20 times stronger than EPL and Palmaris Longus, which are common tendon grafts. When you transfer a tendon or muscle tendon unit, generally the rule is that it loses 1 grade of power. So you've got to consider that in your transfer. You need an expendable donor. So you don't want to take away a muscle tendon unit which is going to have a very important function and be left with a further deficit. Luckily in the upper limb, generally there is a lot of redundancy. So yeah, for example, there's 3 main wrist extensors, so losing one of these generally has very little residual deficit. You want a straight line of pull, so you want the ultimate biomechanics to be working for you. So ideally, you'll do an end-to-end type anastomosis rather than end-to-side. However, if you want to be able to take down the anastomosis, such as for a temporary tendon transfer, you may need to do an end-to-side. The synergy of the transfer is also important. So you note in the hand again that certain muscle groups work together. So wrist extension and finger flexion work together. Therefore, this will lead to the greatest synergy, such as an FCU to an EDC transfer, which is pretty common. So when you work with muscles which are synergistic, it's much easier to retrain these muscles, shorter period of rehab, earlier return to work. You don't want these transfers to take on too many roles, so you want a single function in general. There's one exception which is commonly used, whereby one tendon can restore movement in more than one digit. You can see here in the diagram, FCU is restoring movement in all of the EDC, extensor digitorum tendons. And probably the most other critical surgical step is to get the correct tension on the transfer. So this will give you the best biomechanical force generation across all the ranges of movement. So you want to replicate the premorbid tension within that tendon unit. And the idea is to slightly overcorrect it, because it will become more lax and lengthen out over time. As I said, despite this, the patient can improve it with that tenodesis effect, so moving their hand in different positions to help with that tension. And to overcorrect, depending on what side of the hand or what tendon transfer you do, a general rule is that you can imagine in a resting position, as you move from the radial side to the ulnar side, the finger's in a more flexed position. So if you're transferring to a tendon to flex the fingers, you want to replicate the finger on the ulnar side, which will be slightly overcorrected. However, if you're transferring to the extensor side, you want to move towards a radial digit, which will be more extended. So that's a general rule. So then moving on to the planning for the transfer. Most of the techniques I looked at, they all describe having a 3-column theory. So these are the important things you want to know before the operation. Number 1, what functions need replacing? So is this a young person, manual labourer? Is this an elderly person that just needs a pinch grip? Is this a quadriplegic that needs extension of their arms to push their wheelchair? So it's going to differ depending on the type of patient you've got. what donor muscles are available. So you want to chart down every muscle that is available, check their power and document that clearly. And then after discovering these two things, you want to look at which transfers are required to achieve the surgical goals and come up with a clear plan in this regard. The surgery itself, you want to carefully plan the incisions. So you don't want any scarring, you want the tendons to be able to glide freely. You want careful mobilisation. You don't want to injure the tendon which has been transferred. So be very aware of the neurovascular pedicles. And as far as tunneling goes, again, you don't want to create any small windows. You don't want to get any fibrosis or scarring, which is going to prevent the smooth gliding of the tendon. So I'm going to go through the common tendon transfers that we're likely to see and break these up into the individual nerve palsies. So in regard to radial nerve palsy, the main deficits that we want to recover are wrist extension, finger extension, and extension and radial abduction of the thumb. So with a high radial nerve palsy, you want to try and bring back wrist extension. So the classic transfer is pronator teres to extensor carpi radialis brevis. So you can do this as an early transfer. I mentioned an internal splint, so instead of doing a wrist stop splint for a year while you're doing a nerve graft and that recovery, you can actually do a straight ECRB graft straight away with pronator teres, thereby preventing the need for a wrist drop splint, and you can take that down once the nerve graft has done its work. So if you're going to do it early, you generally want to do an end to side so you can take it down, but if you've got no chance of recovery, you do an end to end transfer. So here's an example of the graft. So you mobilise in pronator teres. We know that pronator teres actually inserts further up the forearm than ECRB. So generally you take a sleeve of periosteum to help lengthen out the graft, as you can see in the diagram on the right. Restoration of thumb extension is very important, and generally Palmaris Longus is used. So in this case you want to reroute EPL onto the volar side to help with the biomechanics and the line of pull. You can also use the ring or middle finger FDS, which was described by Boys, and here you can actually split that FDS tendon into two, so you get EPL and extensor indices. So with Palmaris Longus, there is an issue. Obviously 70 to 80% of people have Palmaris Longus, but there will be a group of people that don't have that tendon. So you've got to consider that. Restoration of finger extension. So this has historically been the use of flexor carpi ulnaris, but there are some major drawbacks. So if you lose your radial nerve and FCU is taken, you'll have nothing to help you ulnar deviate your wrist, which is important in multiple activities. Therefore, you'll get a lot of radial deviation that can cause issues. So this transfer, again, you can see this one tendon for FCU being attached onto all 4 EDC tendons. And then you can do a type of end-to-end also transfer with a tenodesis of EDC in the picture on the right. Other options, so FCR can be used, which is prescribed by Brand. And this one is a bit more complex, described by Boys. So you're using the flexor digitorum superficialis tendons to 3 and 4, and then you're splitting those and then individually putting them onto EDC and EIC. So one of the principles I talked about was better excursion. As I mentioned, that the flexor digitorum tendons have the best excursion, and therefore they're likely to be better for EDC in this situation. Especially if you've got a fused wrist. When you've got a fused wrist, you can't use that tenodesis effect, therefore you want the best excursion possible. However, they're not synergistic, so extrinsic flexors of the hand in flexion and extension are not synergistic, therefore, as I mentioned, there'll be more retraining involved. Median nerve palsy is different to radial nerve palsy in the fact that sensation is probably more important than power. Any tendon transfer with a lack of sensation is not going to work. Therefore, you always want to have nerve repair or grafting as your first priority. The functional deficits we want to try and correct are opposition of the thumb, FBL function, so thumb flexion, and index finger flexion. So with a low palsy, you're going to want to try and recover the function of the thenar muscles, so abductor pollicis brevis, opponens pollicis, and the superficial head of flexor pollicis. Some people have anomalies of these type of muscles with ulnar and median nerve, so you've always got to have a careful planning with this procedure. With a high median nerve palsy, this is above the AIN origin, and you've got all the flexor compartment forearm muscles paralysed apart from the FCU and FDP, the ulnar side. However, despite this, there are other muscles that flex the forearm and pronate, so you generally don't have to do a transfer for those movements. So the very important restoration of opposition. It's a complex movement involving abduction, flexion and pronation of the thumb. Studies have shown that the ideal insertion for the transfer is the insertion of abductor pollicis brevis. And often contracture release is required, so you do this in a separate procedure prior to the transfer. So your options, there's three main options: flex digitorum superficialis, extensor indicis, or Palmaris Longus. So with FDS, you want to try and improve the biomechanics by creating a straight line of pull. So generally you will create a hook using the piezoform or a little loop of FCU. With FDS, that's also supplied by the median nerve, so this is only in a low palsy, otherwise it won't work. However, it does tend to weaken grip slightly. So we can see there's about 4 incisions required for this over the volar surface, and in the bottom picture we can see there's a loop being raised from FCU to help with the line of pull of that tendon. You can also use extensor indices. This is a more expendable tendon, and when you've got a high median nerve palsy, this is the best one to use. So you take this and move it around the ulnar side of the wrist, and again you get quite a straight line of pull for the function. Palmaris Longus. This is mainly described in use when you're doing when you've got someone with carpal tunnel syndrome with wasting of the thenar muscles. It doesn't help much with pronation and flexion of the thumb, therefore it's not true opposition. However, you get very little loss of function with Palmaris Longus, and you don't require much bigger incision than one with a carpal tunnel release, so it's quite useful for a combined procedure there. When you want to restore index and thumb flexion, generally Brachioradialis is used to flex Palmaris Longus and ECRL to FDP. However, with these two movements, generally reinnervation is pretty likely, so you want to do an end to side rather than an end-on-end anastomosis. So here's an example of these. Generally a tenodesis of the flexor tendons, and then you've got Brachioradialis being attached to FPL. So with an ulnar nerve palsy, there are several deficits you want to try and correct. There's a major deformity, which is clawing of the hand, and that's especially bad with a low nerve palsy. The reason for it being worse with a low nerve palsy is that you have also no deficit of FDP. So the FDP actually creates more flexion of the IP joints, making the clawing deformity worse. You'll weaken the hand by about half, and the pinch strength is reduced by 80%, which is very important for the fine motor function of the hand. You'll get asynchronous motion, so you actually get flexion of the IP joints before flexion of the MP joints, and loss of lateral finger mobility. So there's several different deficits you want to try and correct in this regard. So low nerve palsy, below innervation to FCU and FDP. You've got multiple muscles affected in the hand: the interossei, the ulnar two lumbricals, hypothenar muscles, and adductor pollicis. With a high nerve palsy, FCU and FDP are also affected. So when you're trying to restore flexion at the DIP joint, so you can do you can do adjacent suturing or a tenodesis of the ulnar two digits to the middle FDP tendon, which is supplied by the median nerve. Opposition, generally we use ECRB or Brachioradialis, and because these tendons are much shorter, you want to get a tendon graft, whether it be an autograft or allograft, and run that round the second or third metacarpal to again help with the line of pull. You can also use a ring or middle FDS, which is another option. Chlorine is quite a complex correction. So you don't have to do a tendon transfer for this. One way is by blocking MCP extension, so either by a bony block or a capsulodesis or capsulorrhaphy on the volar aspect to prevent MCP extension. The other way is to augment MP flexion and IP extension by tenodesis or a tendon transfer. So these ways of blocking the extension of the MP joints. On the left-hand side, we can see a capsulorrhaphy, so you're opening up the A1 pulley and then tightening that down over the volar aspect of the MCP joint, so preventing extension. On the right-hand side, this is a dynamic tenodesis, so using a tendon graft, running that through the extensor retinaculum and back through the lumbrical canal onto the radial bands. So as you want to try and flex the fingers, this will flex the MCP joints and prevent flexion of the IP joints. And then this is a way of doing a tendon transfer to prevent clawing. So you take the FDS, this is described by Stiles Burnell, and you grab the FDS tendon from either the ring or middle finger. You actually split it into 3 or 4 individual slips, pass that again through the lumbrical canal and attach it to the lateral bands. So that's a dorsal apparatus. So again, that will cause extension of the IP joints and flexion of the MP joints. And this is another type of tenodesis, so where you actually detach the FDS distally, pass it through the A1 pulley on the volar aspect, and suture it back to itself. So this will help with MP flexion. So they're the main type of tendon transfers that you use. Occasionally you'll do a tendon transfer for a more proximal nerve palsy. So your options here for elbow flexion are to take pec major or lat dorsi and insert it into biceps, or you can actually take off the entire common flexor mass and place that more proximally on the humerus, which will help you flex up the elbow. For elbow extension, you can use either deltoid or lat dorsi or biceps and attach that to the triceps. So when you've got a closed tendon rupture, this is something that we will see with distal radius fractures occasionally. So the most common one is EPL rupture. So you take extensor indices, which is on the ulnar aspect of the extensor digitorum tendon to the index finger, and reattach that to the EPL. It's quite an expendable tendon, so generally you have minimal loss of function with that. With a rheumatoid hand, the most common deficit we'll see is that the extensor tendons rupture. They generally rupture from the ulnar side of the hand to the radial side. The rule here is that if you lose one tendon, you can simply suture, for instance, the tendon to the little finger, just suture that on with a tenodesis to the ring finger. However, if you've lost 2 or more tendons, you either have to detach the extensor indices and bring that across, or use Palmaris Longus or FDS to help with these transfers. And lastly, with aftercare, pretty common sense here. Use a back slab to start with to take the tension off the transfer. So if you're doing a tendon transfer to a wrist extensor, you want to put that in about 20 or 30 degrees of wrist extension. Wound check at 2 weeks and recast. Generally, you get the hand therapist to make a splint around 4 weeks' time and start some gentle mobilisation. This will then be increased with muscle retraining therapy around 6 weeks, and strength exercises and weaning of the splint at 8 weeks. With upper limb transfers, you can start full activity pretty early at 12 weeks. If all goes well, you'll be back into work. And that's it.